We are live.
Good afternoon, everybody, and a very warm welcome to this module 4 of myopia control programs in children. So, this module is basically directed towards pharmacological options. Principally, we would be taking care of or talking about low dose atropine, various concentrations of low dose atropine, and what would be the indications in which we can prescribe low dose, low concentration atropine. The newer drugs we will be taking in the module 9 or 10, where we will be talking about the future of myopia control and what new drugs are available. So I would now like to give the audio to Dr. Satya and Dr. Lakshmi to introduce the speakers and experts.
Good afternoon, all, and thank you, AIOS and Dr. Jitendra sir, for this opportunity to be moderating this session. And as mentioned, this is the 4th module on the certification course on management of myopia. And there, like has been seen frequently, there have been so much new technology, spectacle technology that seems to have keep coming. But I would say atropine has been around the longest, though we're still figuring out the dose, figuring out the nuances. And so we are honored to have an expert panel with us here to help discuss the nuances of atropine also. And the speeches have also been very well decided and looking at 0.01, 0.05, and then how we are also going to decide which is the ideal situation. So I'm honored to have Dr. Elizabeth Joseph ma'am from Little Flower Hospital, Langamali. Dr. Meenakshi ma'am will be joining us soon, who's been one of the pillars of the SN Pediatric Department and now has her own practice at Chennai. Dr. Frederick sir from Arvindai Hospital, Pondicherry, who has also been one of my mentors. And Dr. Siddharth Kesarwani from JNRI Hospital, Mumbai, and also a proud LVP alumni. So it's a great honor to have you all with us. And the first speech is by Dr. Prachi Agashi. And Dr. Prachi is from Agashi Hospital, Mumbai. She has over 15 years of experience in pediatric ophthalmology. She has done her pediatric ophthalmology fellowship at Arvindai Hospital, Madurai, so where I've had a chance to get to know her, and also a ROP fellowship from LVP. So we begin the first talk with the effect of 0.01% of atropine eye drops in myopia control. Over to you, Dr. Prachi.
Thank you, Dr. Satya, for that introduction. And once again, a very big congratulations to Dr. Jitendra Jethani sir and Dr. Namrata madam and AIS for this nice initiative. So I'm going to talk about 0.01% atropine eye drops in myopia. Is my screen visible? And
Yes, Doctor.
Yes.
just a second. So I'm going to talk about the effect of 0.01% atropine eye drops on myopia control. So the way the presentation is going to go is I'm going to try and answer these questions and try to talk about the recent evidence about the use for or against it, and then try to summarize the critical points that we can all use in our clinics for using it. So why we need this? I think the previous modules have nicely answered this question. Though the COVID pandemic has abated, the myopia pandemic is really haunting us. And we know that myopia is increasing in alarming proportions. Also, the increase in myopia tends to cause these complications in the eye, which cause a lot of loss of productivity. So we know that we need to take steps to try and control the progression of myopia using some evidence-based methods. Now, how does low-dose atropine work, or how does atropine work? So atropine is basically an anticholinergic drug, and it acts on the muscarinic receptors of the amacrine cells in the retina. And the dopamine is released from the retinal cells, which causes an inhibition of eye growth. Another postulated mechanism is its binding to the scleral fibroblasts and causing scleral remodeling, affecting the thickening of the scleral fibrous layer and reduction of the extracellular fibers. Having said this, these are all postulated mechanisms, though we don't know the exact mechanism of action of. It was first used by Donder to try and treat the accommodative spasm in mice. It was a long time back. However, we are convinced that it is not accommodation that we are trying to achieve myopia. Now, whom to start this treatment for? It's basically the school age group of 5 to 15 years, where the refractive error has been assessed for cycloplegic refraction and progression has been. I would put point of risk assessment of myopia, which I'll just elaborate in the next couple of slides. And also, we need a workup of the biometry to ensure that the myopia is axial in origin, along with an orthoptic and an accommodative work, which has all been covered in the previous. Now, coming to the assessment of risk, there are two parts to it. An increased risk of onset when there is parental history of myopia. The myopia is more than what we expect for a particular age or is worsening very quickly. East Asian ethnicity, excessive near work, and limited outdoor time. And also, along with these factors, age is an important factor when the onset of age is less than 9 years. So there's this nice myopia risk assessment score that has been published by the LV Prasad group, which considers these 10 factors of the history as well as examination, which we all use in our myopia workup. And this has been given scores like low risk, intermediate, and high risk 1, 2, and 3. And the addition of these scores, if it is more than 41.5, then the child is at higher risk of progression, while it is less than 41.5, the good part about the score is even if we don't have all these 10 parameters and we have even till only 4 parameters, the risk can be assessed through a particular test. So these are the cutoffs that are provided based on the parameters that we have been the information about, and then we need to follow these parameters successively to assess. Now, how did 0.01% came to be used in the first place? So we all know that the end of the 20th century was marked by these remarkable discovery of atropine being able to be used for controlling myopia through the ATOM studies. So the ATOM 1 study had compared 1% atropine versus placebo, while ATOM 2 study had come in to try and address the issues or the side effects of 1%. Compared these lower doses of 0.5, 0.1, and 0.6. So it was so serendipity that actually the ATOM 2 trial got into for the 0.01%. Because though it was introduced as a control in the study, it eventually showed that it had a very good outcome and had a favorable balance of myopia as well as less side effects, as well as least rebound. Hence, eventually, from after the ATOM studies, it was that 0.01% has decent efficacy and excellent tolerability, and hence it started being used myopia. The validity was tested in Indian children through this high ATOM study done by the AIMS group, which compared 0.01% drops versus placebo and reported 50% lesser progression in group versus placebo. However, no significant effect on the axial length elongation was noted in the 1 year. So eventually, as the science is progressing and we are gathering more evidence about 0.01%, these are certain issues that are coming to the fore. That this 0.01% has no significant effect on the axial length. The dose-dependent response, younger age group, and its comparison against the optical information. So I'm going to just touch upon each of these points with the recent. So basically, we now have enough evidence that shows us that 0.01% has minimal, no effect on axial elongation, though it has variability in statistics. Few trials have reported statistically significant reductions in the axial elongations. However, effect sizes are small and probably clinically unlikely to be clinically meaningful. So this is a forest plot about the various studies that have been conducted involving 0.01%. And we can see that the effect it has on the axial length elongation is very minimal and is very close to the null line. So this really demonstrates that it does not have a very significant effect on the axial length. Now, some clinicians do kind of want to understand as to why are we prescribing 0.01% as the primary premise of controlling myopia, is controlling axial length elongation, and not just the spherical. So it has been the use of 0.01% has been questioned. There has been a dose-dependent response and question of it controlling myopia well. Younger age group is also a very, which has been tried to be answered through the LAMP study, which tested three concentrations of 0.05%, 0.001. I'm not going to dwell into the detail, but we all know that 0.01% was deemed to be the most effective. But also, this study brought to light the fact that there has been a dose-dependent response at a higher rebound. So when the concentration is higher, the rebound is higher when the drug is tapered and stopped. Hence, again, the question of 0.01%, whether it's a radial treatment be given, is being questioned, because through this study, it was proven that 0.05% has the best of both worlds, the least side effect and the better. Now, coming to its benefit against the optical interventions. So again, when head-to-head comparisons are made, it has been proved that optical interventions are 3 times greater than 0.01% atropine over a period of 3 years. So this graph clearly shows that the excellent effect that atropine has on the axial elongation as compared to optical treatments is very minimal. In fact, it's almost comparable to the progressive additional lenses, which are not that much used for myopia. Hence, an argument that is put forth is only we are missing the opportunity to intervene with a better effective treatment. We are just starting the child on 0.0. So with all of this in the background, what's the real standing of these 0.01%? Well, I'm now going to try and put forth the points where we can actually use this and then try to summarize this issue. So the role of ethnicity. So the Indian eye atom trial showed us that 0.01% did significantly reduce the spherical equivalent. Also, the studies conducted in the white population, so the CHAMP and the mosaic studies, demonstrated significant reductions in the spherical equivalent as well as the axial elongations. These were the kids wherein even the axial elongation was well controlled. So, though the effect size of this drug remains modest, the relative reduction in axial elongation is probably more meaningful in the non-Asian population as compared to the Asian children. So, this drug is going to be more useful in the white population as compared to our population. Now, how does age matter? Early childhood is marked by a rapid physiological axial elongation, which is accelerated, and a higher propensity for higher mind. So the younger fast progressors may actually outgrow the effect of this drug very soon and may need higher concentrations or combination. Older children, so older children is basically children more than 10 years and who are slow progressors. So slow progressors is less than 0.5 diopters per year. The physiological eye growth has largely stabilized, where this drug is a reasonable and very effective option. Age-adjusted dosing is supported by evidence with comparative outcomes achieved in using higher concentrations in younger children and 0.01% in older children who tolerate the side effects of this drug. Also, it was demonstrated by Lee et al. In her study that myopia progression in 6-year-old children receiving 0.05% was comparable to 8-year-olds being treated with 0.025% and 10-year-olds receiving 0.01%. Now, coming to the combination therapy, so it has again been proved in the recent studies that combination of 0.01% along with either orthokeratology or the defocus spectacle lenses definitely outperform just singular treatment with 0.0. So the reductions reported are to the tune of 28 to 50%, and even the axial elongation is sometimes reported is less than 0.1 mm. So the synergistic effect of them together of 0.01% and the optical is most pronounced in low myopes and especially during the initial 6 to 12 months of suggesting that probably a combination treatment or 0.01% may have a better role in combination treatment than just a singular pharmacological. Now, coming to the issue of rebound effect and take. So basically, as I said earlier, the lab 3-year data showed us that during the washout period, there was significant initial elongation and rebound of muscle. Also, the ATLAS studies, which studied the 20-year follow-up of the ATOM 1 and ATOM 2 participants, eventually said that the rebound occurred even later in life, and the initial effect that the participants had received after receiving atropine was completely lost, and the myopia progressed even. So we know that higher atropine concentrations are associated with greater rebound of myopia. So 0.01% has a role to play as this rebound and stop. Now, when to start actually treatment for myopia is basically when myopia progression is noted. We assess the risk and then decide on the correct concentration. Start with the least dosing frequency of once daily and ensure to have a follow-up 6 to 8 weeks after starting. On follow-up, look for side effects in the form of blurred near vision, pupil dilatation, induced phorias, and accumulation line. All of these seem to be least with 0.01%. How long do we need to continue treatment? A minimum period of 2 years. So we need to have some chair time with the parents explaining the duration of treatment. However, it can be continued safely even for a longer duration in even 14, 15 years of age, depending on this. When we actually stop treatment, so a minimum therapy of 2 years is mandatory. If pixel length and refraction is stable for over a year, initial 2 years, then we can consider withdrawing. However, it is recommended that the drop should be tapered prior to stopping the therapy. Based on the risk, we can continue treatment till 14, 15 years of age or think of substituting it with optical methods and closely follow for rebound or progression after withdrawal of therapy. So, to summarize all of these issues, 0.01% is widely adopted worldwide for myopia. Risk assessment with complete workup of myopia is important. Non-Asians may have better efficacy with 0.01% compared to Asian children with singular treatment. 0.01% has minimum effect on pixel length elongation, though it is found to be useful in curbing the spherical equivalent. In younger children less than 9 years, avoid singular treatment with 0.01%. Either start with 0.05% or choose a combination treatment. For children more than 10 years and slow progressors with less than 0.5 diabetes, we can consider single pharmacologic therapy with 0.0%. There's excellent tolerability with respect to side effects of pupil dilatation and accumulation with this concentration. It has a role in step down of higher concentration of atropine and can be used for tapering of treatment to reduce the rebound of myopia after cessation of atropine. So we have all of this in an armamentarium and we should choose our options very wisely. Thank
you. Thank you, Dr. Prachi. There is one question from the chat, which I will first ask you to answer. Why less than 9 years, no single treatment? Why not just start with 0.01%, which is what most of us, the majority would be doing?
I agree, probably, but the more and more evidence that we are gathering is basically when the child is less than 9 years. 9 years is a cutoff, a part of the risk assessment. When the child is younger, the propensity for the child to reach or increase myopia is comparatively higher. When I'm saying this age, it is along with the other risk factors of parietal myopia, increase near the lifestyle of the child. So in these kids, it might probably maybe a better idea to start higher concentration drug because we are looking at a treatment duration for a longer time. The child is being 7, 8 years or even sometimes 5, 6 years old. We are definitely wanting to control have some myopia control till at least 16, 17 years of age.
I'd like
If
to
any of the panelists have.
I would like to ask Meenakshi ma'am, whether what would you be, your preference? Would you start at 0.05% as the first thing, or always start with 0.01%? And also about there have been things of the way give it once a day or switch it to twice a day for 0.01%. Your opinions on?
Well, I think I'm a bit old-fashioned, and I think I will start with usually with if the progression, say if the child is less than 9, you're talking about children less than 9, right? So I would start with myopia control spectacles, add the 0.01%, and follow the progression very closely, but will not hesitate to switch to 0.05 if I find they are progressing despite following all the treatments and following the lifestyle modifications. Plus, if there is a high risk due to family history, strong genetics, then I would not hesitate to switch to 0.05 if I'm not satisfied.
Thank you, ma'am. From Dr. Elizabeth, ma'am, and the other panelists.
I was looking at all the recommendations by International Myopia Institute and WHO and all. WHO recommends 0.05% as initial therapy in younger children, whereas International Myopia Institute recommends 0.01%. So there is some controversy here, but as practitioners, we usually start with 0.01 because that was in the market to start with. And we find that there is very good response to 0.01% atropine. And if there is any resistance or still if the axial length or the refraction is progressing, we switch on to 0.05%. That is the current thought.
Dr. Meenakshi ma'am, you wanted to add something. You're muted, ma'am.
I forgot to compliment Dr. Prachi on the excellent presentation. Very succinct and comprehensive. Excellent.
Dr. Siddharth, would you advocate 0.05% on the first, as one of the first line? You're muted, sir.
Yeah, thank you for that question. Again, excellent talk by Prachi. Congratulations to you. I differ in a way that, in fact, no therapy when you meet a patient for the first time, and you are starting on 0.01%. That is not monotherapy because you are asking him to do some lifestyle modifications also. Lifestyle modification and 0.01%. That is also a combined therapy. That is not a single therapy. If at some circumstances, rarest of rare, where somebody is impossible for them to do any lifestyle modification, for whatever circumstances there may be, then you have to go with a more potent intervention. Otherwise, you start with lifestyle modification and atropine. And if it is a younger child, I would maybe call them 3 months later and check whether he has progressed, and then step up the treatment to twice a day atropine or 0.05%, or add glasses, whatever. So lifestyle modification is one of the interventions. We have to remember that, and it's a very strong intervention because in absence of lifestyle modification, most other interventions don't seem to work. So that's my take on it.
That is true. I mean, we assumed the lifestyle modification was on the list, but yes, we should always mention it. So one of the things is with 0.01% side effects are very low. So do you call back the patient after 1 month? So usually when we initially started, when I initially started, I would always see the patient back after 1 month, and not having seen any side effects, I don't do such a close follow-up for 0.01. But if I started on 0.05, it'd be a different thing. So what would be your thing on that, Dr. Prachi?
I definitely call the patient once after 6 to 8 weeks. Okay. I agree that the side effect profile is pretty safe, but I have had 1 or 2 kids who have had an accommodative lag. So it has been rare. But as a protocol and following the consensus statement which the GPOS group I make it a point to call the patient once after 6 to 8 weeks. Just do these 2-3 tests to make sure that there is no accommodation, there is no dysphoria, and then follow up the child every 6 months. That's
Dr. Frederick, sir, there were just 2 questions from the chat related to if there were side effects with atropine, what would you do? And if a child 14 to 15 years is progressing after tapering atropine, do we continue? And at what age should we stop?
Yes. Thank you, Prachi, for the very detailed presentation. As far as the side effects, I think we have not seen much till now. Very few children, they slightly complain of some mild near vision. Initially, they find it difficult to read. They see that there is a difference when they put atropine, but that gets all right within a week or something like that. And usually we don't see any changes in the pupil diameter or anything like that when they come for follow-up. As far as 0.01 is concerned, I think it's very safe. And with respect to recurrence, yes, I would rather reevaluate the patient, look for the risk factors, maybe lifestyle modifications, maybe start once again or even plan for a DIMS glasses. So preferably what I personally feel is in young children, even though we talk a lot about atropine drops, compliance is a very, very important factor which we should consider. So even though parents say that they put mostly the compliance is only 40 to 50 or 60% max. So as a conservative approach or a safe approach, I would rather prefer starting the children, younger children or relatively older children with glasses first, if they are able to afford, than rather starting with that.
Thank you, sir. And like you said, the affordability makes one of the big advantage of atropine always still being on the line. So then before moving on to the next question, which is more related to the 0.5%, we will move on to the next talk. And I will hand over to Dr. Lakshmi to introduce our next speaker.
Thank you, Dr. Satya, and thank you, Dr. Jitendra Jatani, sir, and AIOS for having us here with a great set of panelists. So then for the next talk, I would invite Professor Jasprit Sukija from PGI Chandigarh. I think he doesn't need any introduction to the ophthalmology crowd. So I hand over the mic to you, sir, for talking to us about the indications of 0.05% atropine. Over to you, sir.
So, thank you so much for the kind introduction, and thank you, Dr. Jitendra, for inviting me to this webinar, and AIOS as well. So Dr. Prachi has said a lot of things where 0.01% would not be useful, and that is where 0.05% comes in. So a lot of things, we are moving on to 0.05%, and I'll be taking you through some of the aspects, some of the favorable points, some of the controversies with 0.05%. So as has been rightly said in the previous presentation, it's just this myopic epidemic is just keep increasing. Now, why it matters to control all these things? It's basically, we are having an increase of prevalence. So over almost 1 out of 3 children worldwide are currently myopic, with the prevalence steadily rising across all the regions. Now, if you consider the East Asia impact, it's almost 80 to 90 prevalence. And it's more among teenagers and young adults in the metropolitan areas. And if you take the 2050 projection, I mean, half of the world is going to be myopic. But so why it's important? Because this myopia, if it's coming at an earlier age, there's a faster progression and there is a higher lifetime risk of pathological sequelae. So that's what's happening in the world, and that's what's projected. I mean, if you see these high myopia, this is high myopia. And considering 2020 here, and by 2050, you see it's almost going to be double. So that is why we need to just hold on to these things and prevent its progression. And a similar thing is happening in India, if you see this graph on the top. So that is why it has become important, such an important thing to control it at an earlier age. So why is there a shift in practice to higher concentration? So a lot of trials going on. We do not have so many studies with the 0.05% atropine. So we would get them in the coming years. But yes, low dose atropine has been shown to reduce refractive progression, but not a significant impact on axial progression. So all the more reason. So why it's important here? Because if you see the myopic maculopathy, the odds are at 2 times at -3, and they just increase considerably the moment it goes to high myopia. So that is why you have to prevent the axial elongation. And higher concentration has been shown to retard axial elongation. And young children require higher concentration for a treatment effect, as has been shown by the LAM study. And if you initiate 0.01%, that is the lowest dose probably, it could result in delay in implementation of an effective dose, as progression is more rapid during the stage. And of course, you have associated factors for poor response to low dose atropine, which are still not clear. So the key point here is the increase in axial length is more strongly correlated with developing pathologies like retinal detachment, glaucoma, myopic maculopathy than the dioptric value of the refractive error. So with 0.01% was basically what we were seeing was the dioptric power only. So our aim is to reduce the axial length growth, leading to a reduction in both the refractive correction needed and the associated pathology. So what does evidence say? So what do we have in literature? Well, how 0.05% started was on the first report from Taiwan, where it was used due to intolerance of the side effects of 0.1% atropine. So they were using quite a high dose, 0.1%. And that's how this started to come in. So degree of axial length elongation prevention with lower dose atropine is highly variable among studies. So you have so many studies, some say mild, some say moderate, some say there is just no effect on axial length elongation. And when you have a combination of these meta-analysis and systemic reviews, they found only a small annual effect of size on 0.01%, but then which improved with increasing concentration, that is 0.05%. And what they found was that the axial length control for the 0.05% dose approaches that of 1% atropine. So it's not similar, but really just coming slightly closer to that. So if you see these RCT network plots, you have so many studies, because if you see the size of this circle, basically this is the spherical equivalent, the refractive change, and this is the axial length change. So if each node basically shows the number of participants. So it's a larger, that means more number of participants. So if you see these randomized control trials, you see atropine 0.01%, so many of them, so many participants, and the thickness of the line shows the number of trials as compared to just 0.05%, where you see a very small circle and it's just thin lines. And similarly, the case when you're seeing the axial length changes, the number of trials are just too few, the number of participants are few, and therefore it will take time before we have a good, reasonable, convincing answers for 0.05%. Well, some of the evidence which comes from literature, I'll just discuss one by one. It's a higher concentration, so does frequency matters? Well, greater axial elongation in once a week dosing was seen than twice a week or daily over 12 months. So they just have, this was over a period of 1 year. They found no significant difference in axial elongation between dosing twice a week versus daily. Although this was just 1 year, as I said, with longer duration treatment, this may be more significant. The important thing was daily regime group had a more myopic relative peripheral refraction and least myopic progression. So that becomes important here, that the atropine is also acting in this way and decreasing the myopia progression. So coming to rebound, which is creating a lot of controversy, that why the only problem with 0.05% coming up is that the rebound is not being, we don't have evidence for how much rebound it can cause. So in some of these studies where they use 0.05%, they found that restarting 0.05% atropine following fast progression after ceasing atropine treatment results in similar control as those who continue 0.05% atropine without stopping. So you stop it, the patient has progression, again started, versus those who are continuing the 0.05%. Basically, all these showed a similar effect, meaning rebound or continued progression can be effectively managed by reinstating this low dose atropine. Now, loading doses coming to higher concentrations than 0.05% do not appear to provide better outcomes than a consistent low dose treatment protocol, with evidence that some rebound may even occur when changing from a higher to lower dose. So that is the problem which comes if you say that loading dose, we put a loading dose and then come down to lower concentration. Well, the variety of responses to different atropine regimes require more studies because it's so variable. So coming to the safety aspect of this 0.05% atropine, well, all these doses, all these concentrations do dilate the pupil. So it affects the pupil diameter. and the amplitude of accommodation in a non-linear dose response manner, meaning that with steep and small effects for a concentration of 0.1% and a flatter but larger effect at doses above 0.1%. So basically, if you have lower concentration, that is 0.1%, it's a steep but small effect, but a flatter response and a larger effect over 0.1%. Well, there was no statistically significant difference in patients' dropout rate between different atropine doses, although 0.05% atropine showed the lowest risk ratio of dropout because probably it was controlling the myopia progression quite well. Long-term impact of increased retinal light exposure, even from small increases in pupil diameter induced by low-dose atropine, are still unknown. So we don't know what is going to happen 50 years, 40 years down the line. If the patients are going to land up with an early age-related macular degeneration, those answers we still don't have. Well, coming to few studies, I mean, this is one of the most important study which is quoted everywhere. The LAMP study, where they use 3 different concentrations and initially 2 years of treatment, followed by 3rd year washout in one group, and they analyze the data after 5 years of treatment. So basically, the important thing here is, not going into the details, is that in all those children who needed to restart the treatment after a washout are almost similar in all the 3 concentration groups. So 0.01, 0.025, 0.05. Meaning that this really was not affecting the retreatment. So they found that retreatment was associated with a younger age, but not with atropine concentration, sex, or baseline spherical equivalent. So what are the inference from that study? Well, if you just have a simple comparison between 0.01 and 0.05, you can see how it reduced the spherical equivalent progression, how it reduced the axial length progression, although photophobia was much more. So it had a dose-dependent effect and had good tolerance over 5 years. And what they recommended was it should be continued for 5 years with accommodative amplitudes and photopic mesopic pupil size, which was same across all the groups. Now the rebound probably after 5 years, they will still have to see what is really happening. Initially, what they found is probably an acceptable rate of rebound, which is quite palatable. So if you see this charts here from the LAMP study, the LAMP1 study, if you see the spherical equivalent reduction, you can see the highest is with the 0.05% and similar is with the 0.05% as compared to 0.025 and 0.01. And if you see the reduction by how much it is happening, so the reduction in myopia is just 13.4 and the fast myopic shift is 16.3, whereas the reduction is quite significant here. Even in the fast myopia shift is reduced by 53.6%. And so coming to the efficacy, the 2-year cumulative incidence rates of myopia and the fast myopia shift at 2 years are maximum in the placebo group, 0.01%, almost similar here, but the greatest effect is seen in the 0.05% atropine group. That means the fast progressors are also having a good reducing effect. So coming to the another study, basically some of these randomized studies, this is the MOSAIC trial where in their extended study in the placebo group, where they use atropine 0.05% for 1 year, they found that it exhibited a little less myopia progression as compared to the placebo group. The good thing was tolerable side effects. Rebound, they did not study. And atropine given after 2 years of placebo. So it was given after 2 years. So effect of age could have a confounding factor in decreasing myopia progression in this study. So we have an Indian study by Rohit Saxena. And again, they used 0.05% for rapidly progressive childhood myopia. They studied 40 children, found a significant reduction in myopia progression, even in axial length progression. However, there was no correlation between axial length and spherical equivalent progression. Well, the response to treatment was independent of the age, baseline refractive error, rate of progression, gender, and family history. And the good part, again, was no side effects. So 0.05% is working well in Indian children, at least. So coming to poor responders, now because these responders can be optical treatment not having an impact. So usually used, so if you use it in combination with the ortho-K, so what's the efficacy? So if you see the poor responders in case of orthokeratology, well, in literature, combining orthokeratology lenses with 0.01% ophthalmic solution has a superior effect on controlling axial length elongation compared to using ortho-K lenses alone in those who are ortho-K responders. So ortho-K does have an effect, but if you add 0.01%, probably the effect becomes more. But in those where you actually want to add 0.015% is those who are poor responders, not responding. And so for patients who experience poor control with ortho-K lenses, the addition of 0.01% did not significantly improve control effect. So that's an important thing. But with 0.05% in patients experiencing poor control with ortho-K lenses, the combination significantly reduced axial elongation in the subsequent year. Well, these are retrospective studies. We need prospective studies, more studies, to really have a good conclusion whether what they say is really effective. So specific indications for 0.05%. Well, if you're having rapid progression, that's about 0.3 millimeters a year. Early onset myopia, children, they are known to be fast progressors. High risk factors like two myopic parents or siblings with high myopia, East Asian ancestry. Those are some of the things where you can consider starting a higher concentration of 0.05% atropine. Well, progression threshold for 0.05% versus 0.01%. If the axial length growth is more than 0.15 millimeter in 6 months, if you're doing 0.01, you can change it. If the refractive change, that is a fast progressor in 12 months, or inadequate response to 0.01% monotherapy or glasses. So these are some of the areas where you can think of using 0.05% atropine. So what does it mean for my practice? So these are some of the inferences from the LAMP study. Well, atropine 0.05% appears to work best to control axial elongation. If you see the first year, it's again dose-dependent effect. In the second year, it's still working more as compared to 0.025 and 0.01. Well, third year all had the same effect. So basically in the initial year, it is having a good effect and controlling it. So initiate 0.05%, just like you would do, we have oral steroids. You initiate at a higher dose and go to a lower dose. You can do that, increase it, initiate at a higher concentration and decrease the strength as and when required rather than the opposite. Rebound effect with atropine 0.05% was small and clinically insignificant. No doubt 0.025 and 0.01 group did not have a rebound effect. This indicates that there is still some value in some form of tapering, because the 0.05% was not tapered here, we just stopped. So it's better to taper, and maybe the side effects, the rebound would decrease. So I'd like to conclude here by saying that efficacy of atropine is dose dependent. 0.05% is proving to be a well-tolerated concentration. No study on the rebound after stopping. The maximum effect of higher concentration seen after 2 years, showing myopia plateauing, as was shown in the ATOM2 study. You could shift to a lower concentration thereafter, because even the age, the child would be a bit older as well. And further studies are required to explore the role of higher concentration. Well, the goal is always to slow myopia progression during the years of most active eye growth, maybe the initial choice in younger children. While all concentration of atropine studies produce some physiological effects, 0.05% atropine appears to best balance the axial length and refractive control against side effects and patient acceptance. Thank you.
Thank you, sir, for the wide and concise, concise arrangement of the use of 0.05, because all of us have just started using 0.05, and that's a big knowledge coming from your side. So I would like to know the take of the panelists on 0.05%, and what is your experience with 0.05%, especially in younger children? Dr. Nina?
Yeah, so we have just started using 0.05% since last few months only, since it was launched in India. So I would say that it's too early for me to make my assessments on this short period of duration, but I've seen about 20% children developing photophobia and difficulty with near vision with 0.05%. So that would be something we have to say, whether it's just an initial, adjustment period, after which would they become all right. But two of them discontinued it because they just couldn't tolerate it, the 0.05%, when I switched them over from 0.01% to 0.05. But the rest, they were able to tolerate it when they continued to use for a month. So we need to see, because this is a new kid on the block in Indian scenario. So we need to see how our more pigmented eyes are tolerating this concentration.
And there is some amount of photophobia which is happening in, especially in older children. I've seen that.
Okay, thank you. Frederick, sir, in your take on 0.05% atropine? And Elizabeth, madam, or any other panelist who would like
Yeah,
to comment on starting the kids on 0.05%?
Okay. Thank you, Lakshmi, for that question. And thank you, Professor Jaspreet, for an extensive discussion on 0.05. The problem with us is that 0.05% atropine was not there in the market. So we started with the 0.01 for a long time. For the last, I think, 4 years or so, we are using 0.01. And the results are good. And recently only 0.05 has come. And I have started using it. I didn't find any problem. None of our children came with photophobia and all. What I used to do is that we start with 0.01, and if there is a progression, we add optical treatment. That was our idea till very recently. 0.5% has come. I have started. I think, as I told earlier, there are so many studies available. Some studies say that 0.01% is good enough. Some say that initially itself you start on 0.05 because that is better. So I think we'll have to wait and watch. 0.01 is good. 0.05 may produce photophobia. Combining with optical treatment is a very good option. All the patients will tolerate combination with optical treatment. So my take is that if the child presents to us early, younger child, maybe 6-year-old, 5-year-old, with a good family history and all, then better to start with 0.05%. And if the child is a bit older, maybe 10 years, 9 years, and the myopia is little less, maybe on the range of 1 or something like that, then you can have 0.01%, for which the child will be more compliant. And sometimes the children will forget putting the drops. You can ask the parents before they go to bed, you just put 1 drop each in the child's eye. That's what I do. And I have one question to all of you. Do anyone give atropine 0.01 in the morning instead of in the night?
Can I answer that? So I was sitting in one of the seminars by Dr. Audrey Chia way back in a workshop in one of the APAOs in Singapore. And she mentioned casually saying, if you find that 0.01 in the evening is not working, you can switch it to morning and see. I did that for a bunch of patients, but there were a lot of side effects. Patients did complain about photophobia. Patients did complain about some blurring of vision. And so I went back to night again. Now I don't do it in the morning.
Yeah, so
Ma'am, can I add on? Because I have tried 0.01% twice daily when there was a progression. So before the 0.05% came into the market, we didn't have an issue. Actually, patients actually were okay. So this 0.05% only, I'm having problems with photophobia and all that. So I don't know whether it's something to do with the kind of patients I'm having. BD dosage was very well tolerated, especially we tried when the OD dosage was showing some progression. So we switched them to twice daily dosage. So I would tell them at least 5 to 6 days a week if you're able to put. I think that's fairly good compliance, and most of them are able to do that.
I think the Chennai sun is perhaps more stronger. I'm not sure what it is.
Kochi is also equally bad, ma'am.
No, but I just wanted to add what you said is true. Not all of them came back with photophobia, but there were a couple, and it didn't seem to matter in a big deal as far as stopping progression. And I was more worried they will stop everything because of the side effects. But yes, I agree. Before 0.05 came, we did switch to twice a day. Of 0.01. And sometimes if the photophobia is the issue, then you have to put them in photochromic glasses and give a letter to the school, because many schools object to children coming in glasses that become dark glasses and make them then stand out or be more stylish or cool. And so I think sometimes you'll have to give a letter to the school. Like you said, not all patients, but I did have some that came back with complaints.
Yeah, so we've been using this for a trial, obviously, purposes for the past 2-3 years. And photophobia is one issue which comes. The other thing is headache. near vision problems because the near point of accommodation recedes. We've had fever with it. We've had severe headaches with in patients. So these things do come up with the higher concentration. With the lower concentration, like you're saying, BD doses, there were 3 or 4 patients where we started BD doses in older children. They came back with headache and again difficulty in ear work. So that's our experience here.
I think we had a good experience with twice a day. With 0.05, yes, we have been using it now, like Jaspreet, I think we both were using it for almost 4-5 years. We had around 8 to 10% of children in 0.05% who came back with near work problem and with problems of photophobia. But luckily for us, twice a day has worked very nicely. Although we did do studies to find out whether it does affect near point of accommodation, accommodative lag, and near point of convergence. It does affect, but it is not very significant compared to even 0.05. So we did compare 0.01 twice a day with 0.05%. We did present it a couple of years back in AIOS. I think 0.05 definitely, it is quite significant. You would have to tell the patient, because nowadays what had happened was with 0.01, we had become so complacent that, we stopped even telling the patient that it was atropine. So we were like, this is not the side effects. We were pretty confident that there is no side effect. With 0.05, you have to put in a word that there can be photophobia. The kid may complain of near work problems. So that's a big difference from 0.01 to 0.05. But yes, the effects are better. Even non-responders to 0.01 respond to 0.05 and even 0.01 twice a day. So that is an add-on.
So I just need to maybe add a thing just to share my experience. Now, usually we use 0.05% as a step-up dose in a visit where we have discovered that the myopia has increased. So what happens is we give a higher number and we start them to put 0.05% simultaneously. So with a higher number, again, they have to accommodate more because they were not accommodating that much when the power had increased. And then suddenly now they are not able to accommodate that much. So you should always have a gap between him starting wearing the new glasses and him starting 0.05%. So what I tell them is for the next 15 days, let him wear glasses and continue 0.01% and then shift to 0.05%. So that in 15 days, he will start accommodating as per the new glasses and then the tolerability improves. Because if you increase the number and you give 0.05% simultaneously, a lot of children will complain. And that's why you will see that if they continue using it over 15-20 days, they become more tolerable. So to avoid that situation altogether, you kind of stagger the increase in power and the introduction of 0.05%.
Jaspreet, I have a question for you. And before I ask my question, excellent presentation. My question is, as a referral center, I'm sure you get patients who have already been on 0.01 and the number is changing, but there's no documentation of axial length, which it happens very often. In those, do you consider just bumping up to 0.05?
Yes.
Or what do you use to make the decision?
Yeah. So it's a government institute, so obviously that profile of patients has to be atropine for most of them, not glasses. This is one thing. And the other thing is, yes, we get a lot of patients who are already on 0.01% and they are progressing. So with that, probably the first thing, obviously, we are going to see is they have refraction being done from outside. So we want to first rely on what is our refraction and what is our axial length here. So give them a time of maybe 0.01% for about 3 months and come back to us for a repeat. So if we find that our results are same with the first and the second or maybe an increase, definitely, yes, we would hype up the dose. And we would not consider this in case we have high risk factors, if both the patients are myopic. Like we have parents who come with LASIK done. So they won't be wearing glasses, but when you ask them, they have got LASIK done. So these are the patients where we would step up our concentration. And the important thing is that we've seen patients who have been stable and then suddenly progress at level 12. That is when the growth spots is coming. And in girls, it's slightly earlier as compared to boys. So that is the time we counsel them that yes, probably you should not be stopping any of these things and let it continue, because this is one phase. There's so many patients, so many children we are seeing that stabilizing, and then the growth spurt, they are increasing by almost 2 diopters, 2 to 3 diopters. So we need to have that thing in our mind that yes, it's not just controlled here and need to continue. But yes, we do step up if we have a referral and it's showing progression.
If I may add one more point here, Jitendra gave me the permission to talk, so I'm going to just talk. So along with your excellent observation, Jaspreet, I also find kids are approaching the board exams. So from the 9th and 8th start the NEET coaching and the JEE coaching. So all your environmental modifications are all out of the door. So out of the window, they're all cramming like crazy, and there is just no sunlight in the picture. So I think that may be also a reason why we see this sudden spurt. I know Nina has a kid probably who's been through all this, gone to college and so on. So maybe you can also add, Nina, to this observation.
Yeah. Yes, ma'am. So, like Dr. Kesarwani was telling about the environmental modification. So we do recommend that, but we have kids from Gulf telling them to play outside in the hot sun is just not possible for at least 6 to 7 months of year. So whatever we say, we have to adjust according to their the local their adaptability and their environment. So having said that, we do tell them you do have to go out and learn to do some outdoor activity, but it's better said than done. Very difficult as they come towards the higher classes. Most of them are onto online classes and tuitions, and that's when we do see. In fact, we even see young adults also progressing when they are engaged in continuous sustained near work. So I think that is something definitely we have to give into consideration. Our lifestyle itself is contributory to this.
Like Meenakshi Madam told, to add on to this, I would like to ask the panelists on how do we follow up these children every visit? Like, do you include the actors also every time? Cycloplegic refraction, and some places, like ma'am told, that axial length will not be available. Like every place may not have an IOL master or such things. So how do you accommodate for that? Because contact or immersion, sometimes you get an axial length of a particular value and then the next time it appears actually lesser. So how can we follow up them up in such situations, and every time what all to monitor? The question is open to the panelists.
I'm
Meenakshi
talking
ma'am,
too
can you
much,
have a
so
take?
I thought that somebody else can talk, but I'll just answer very
Cedric,
quickly.
sir,
So
yeah.
I feel I cannot preach something and practice something else, right? We talk about axial length, axial length, axial length, and then in your own practice, you cannot dodge that because you don't have a access. So I didn't have access. Now I'm in a different practice. I do. So what I used to have is I used to have one IOL master availability in North Chennai, South Chennai, Central Chennai. So I used to have one, and these patients will go there only for that, only for the axial length, and they can just WhatsApp it to me, and then we will change the treatment, or we will not change it. I won't ask them necessarily to come back because it's pretty cumbersome to come back with the new axial length. Some of them are very smart cookies. They will take the axial length and come to you. So which is also perfectly fine. So you have all the parameters in front of you to help you make the decision. But axial length is only once a year. I only follow it once a year. Otherwise, every visit is a cycloplegic refraction.
And recently, this axial length corneal radius ratio has been talked a lot about in pre-myopes and myopia progression. So, could Jaspreet sir, could you throw some light on it? Like, should we look at that at every visit rather than the axial length alone?
So that's a very important point. I mean, we do our optical biometry because obviously we have access to it on every visit. We've seen flat corneas with high axial lengths. And so the progression would be like, obviously you might not just have a 2 diopter, 3 diopter, but an axial length of 25 to 26. So there comes the importance of doing this ratios and checking the corneal radius as well as the axial length. And when you're seeing the progression as well, sometimes you're because of the changes in the aberrations, maybe lenticular aberration, maybe corneal aberration, what happens is the refractive power might remain the same, but your axial length tends to increase. It can be a reverse as well. So therefore, it becomes important to know all these aspects when you're dealing with this, because sometimes patients have very steep corneas. So like having a keratometry of 45, 46 or 47. So basically, then what are you going to treat? You need to see the axial elongation, what is happening, not the corneal power which is changing. So here comes the importance of the optical biometry, because in our setup, probably we've seen a couple of patients like this who probably may not be progressing axially, but with a refractive power which is increasing.
Yeah, there is, thank you, sir. And there are two questions in the chat box, like why do we see myopia progression more sometimes even in 25 years age after the eyeball growth has been completed? And maybe they want to ask that whether any treatment is needed in this age.
So basically what you're seeing, if a pathological myopia is going to increase, okay, so that has to be ruled out in these cases. Otherwise, probably at 25 years, it's very unusual to have a simple myopia which is gone on to a high myopia. Some other pathologies is, or you have like you should always check for glaucoma. That's one important thing what we miss. So we need to check that. And if you find everything is okay, probably no harm trying a dose of atropine if it's progressing. But otherwise, it's very unusual at this age. There would be some other pathology that the patient has progressed, is still progressing at 25 years of age.
Okay.
I just like to add that probably in this age group also do a dilated refraction. Many a time it is still pseudomyopia because of their sustained near activity. So if we just dilate, we just see that there is no progression and they are probably, the refractive error is almost the same. In addition to ruling out the pathology that Dr. Jaspreet mentioned, but otherwise it can very well just be a pseudomyopia also even at 25 years.
True. So the IMI says that definition of myopia progression is based on accommodation relaxed. So if you have to say progression, you have to have a cyclo visit. Otherwise, this is not what you're basically seeing. The progression could be because of accommodation as well.
I just wanted to have a quick comment on the axial length measurement. See, the whole point of myopia progression to be measured objectively is through axial length only. See, we all are pediatric ophthalmologists and we do understand that, we do have patients, even after cycloplegic refraction, sometimes when you do a dynamic retinoscopy, most of us have realized that, the kid may still be accommodating. So axial length serves as an objective parameter. We have been discussing this in last meeting at AIS also, whether, I personally start any treatment without seeing axial elongation or not. I do not start. And I do recommend, whenever I say, I do recommend that, if you don't really have axial progression, because all these parameters, all these discussions, arguments of atropine, glasses, and all the drugs are only for axial myopia. As Dr. Jaspreet rightly said, that you're not treating corneal myopia, you're not treating corneal curvatural myopia or anything like that. So you do need an axial axial length as a parameter. And once you have axial length, see, we cannot say that, whenever we are treating glaucoma, that we do not have a particular applanation tonometer, and we cannot say that, we are treating on shorts. So I think if we are thinking, or if we are talking about myopia as a disease and myopia progression as something which is treatable, then we need to have an objective parameter. We have to settle down on some objective parameter. Cycloplegic refraction is definitely an objective parameter, but axial length itself is also another, important parameter which is completely objective.
So the IMI has said in their workup, the International Myopia Institute, they said check the axial length of the first visit, but then this investigation, axial length, becomes optional in their record for the follow-up. So they are investigation, they've written parameters to be checked essential and optional. So on the follow-up visit, the IMI says that this is optional.
That is mainly because of unavailability of the equipments in all the countries and all the places. But if you are treating, you are actually treating axial elongation.
Yeah.
Without documentation of axial elongation, it becomes difficult to know how much elongation is taking place. And even if we don't go on the numbers, like you don't have to categorize your axial elongation in 0.1 millimeter, 0.2 millimeters, but you definitely need an evidence that it is axially elongating. And sometimes, it really helps you in correlating your cycloplegic refraction with the axial length elongation. Sometimes you will actually see that, there is no axial elongation, child is reading 6.6, you have done a cycloplegic refraction and it is coming to be higher. And then you realize that actually it is a sort of a accommodation which kid is doing.
Yes, sir. So we'll just take two questions from the chat box, like any such, how to explain axial length regression on low dose atropine. That's one question that has been asked.
Could you repeat the question? I couldn't hear you.
Yeah. Is there any axial length regression with low dose atropine? How to explain that? So that's the next question. Jitendra,
I think it's
sir,
something to do with the choroidal thickness, effect of atropine on choroidal thickness. We don't have much experience, but I've seen in some journals that atropine has some effect on increasing the choroidal thickness. And I think that's how it is. I don't have any, but I do see, I have seen in one or two patients on subsequent axial length measurements, 1 or 2 points less. So whether it's a measurement error or not, I'm not able to comment right now.
Okay, and one more question is whether there is any progression after LASIK. So anything specific to LASIK after that, whether it progresses?
No. After LASIK, if there is a progression, it may not be due to axial length elongation. It may be due to corneal problem. So in that case, it may not work. Atropine may not work. It is due to corneal problem. Cornea becoming steeper after LASIK, becoming something like an ectasia. So that is not effective. Atropine is not effective.
Okay, we have some questions.
But can I ask you, why wouldn't do LASIK when there is progression, right? So, I mean, in the sense you're talking about after LASIK.
We take subsequent, at least if there is a progression, we won't do LASIK. But sometimes the patient may have -8 or -7 myopia and progression is only 0.5. We correct the refractive error, and there will be only very residual deviation. Instead of waiting after at the age of maybe 2022, there's no point in waiting further. If the patient has got some -6 or -5 myopia and progression is of the rate of about 0.5, then practically there is no need of waiting.
Thank you, madam. So I think we'll move on to the next talk. So I'm happy to introduce Dr. Neena, Head of the Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at Giridhara Eye Institute, Kochi, for our next talk on when, how, and whom of atropine drops in myopia. Over to you, Dr. Neena.
Thank you, Lakshmi, and I hope I'm audible, and I'd like to share my screen now.
Yeah, visible. Can
Yeah.
you please put it on? Yeah.
So I think all the previous speakers have wonderfully summarized all the points which I'm going to talk about it now. It's just going to be a repetition and some reaffirmation. So it's going to be when, how, and in whom to prescribe low-dose atropine for myopia control. So as Dr. Jitendra said, when do you consider myopia control? Only when there is documented progression of myopia. That is when there is a spherical equivalent increase on cycloplegic refraction and there is an axial elongation, a documented axial elongation or axial length measurement. So if there is no evidence of myopia progression with minimal risk factors, observation and follow-up with regular cycloplegic refraction, this alone is sufficient. So before we start the atropine treatment, we'd like to know whether, we have to identify the risk factors. So all of us have summarized this, but still it's good to look at what are the risk factors for the myopia progression. Definitely younger age of onset of myopia. Baseline refractive error is the most important predictor of myopia progression. Parental history of myopia, ethnicity, Southeast Asian ethnicity or East Asian ethnicity to be more precise. Then the type of visual environment, the competitive educational environment with long study hours, reduced outdoor activity, sustained near work, closer working distance, accommodative issues, increased screen time, all these are contributory to as risk factors for progressive myopia. Is my screen moving?
No, it's remaining in the same.
Yeah. So in 2016, it was WHO who said that you could start atropine 0.01% as the first line of treatment if the child was aged 6 to 10 years with myopia of at least 1 diopter and the progression was at least 0.5 diopters per year. So they recommended atropine as a potential first line treatment for myopia control. But then we have come a long way from 2016. That time we just had atropine only as the initial, control measure. But we have a lot of other tools in armamentarium like the defocus glasses, contact lenses, ortho-K lenses, etc. So who is the atropine candidate? So now when we look at it, the age range is very important. Primarily, you should start the treatment, any anti-myopia treatment in the peak progression years. So the ideal candidate should be between 4 to 14 years, the refractive profile of at least 1 diopter of myopia with a documented myopia progression, a spherical equivalent increase of more than 0.5 diopters per year, or axial elongation of 0.2 millimeters per year. Now, the ideal atropine candidate is a child who's intolerant to contact lens use or orthokeratology. This was the Western recommendation, or as a dual therapy booster. To know this, we should know what is the progression. How can we classify progression? We can classify it into mild progressor or a slow progressor, moderate progressor, and rapid progressor, depending on the rate of spherical equivalent change, which is mentioned in this picture. So these are all recommendations based on the various landmark studies and like the atropine, the ATOM study, the LAMP study, and the WSPO's recommendations. So in whom else can we start low-dose atropine therapy? So we can start low-dose atropine therapy in a high-risk child, even with mild myopia, either as a combination or with a higher concentration itself, or as an adjunct therapy in rapid progressors along with other myopia control measures. And of late, it is gaining momentum in pre-myopes, that is, those children who are not yet myopes, but who may become myopes in the near future, and they have these high risk factors like myopic parents with low outdoor time. Yeah, so the combination therapies have shown to be very effective, especially the low dose atropine with orthokeratology lenses have shown to be very effective. And if you look at this graph, you can see that the monotherapy was able to the axial length elongation was 0.46 millimeters per year, but with the combination, it reduced to 0.14 millimeters per year. So definitely orthokeratology with low-dose atropine does work, but as Dr. Jaspreet said, you have to see which dosage will work for you, whether it's 0.01% or 0.05, that we have to work out whether they are responders or non-responders. And there are good reports of good control of with the myopia glasses along with low-dose atropine. Both the DIMS, HALT, CARE, and DOT lenses along with low-dose atropine have proven to be effective. So what about starting low-dose atropine for those with pre-myopia and low myopia for at-risk candidates? So this was some question which was raised by the ATOM-3 study. So can we prevent or retard the onset of myopia in children, even before the onset of myopia has happened, or can we slow down the progression of myopia? So pre-myopes would be those children who are, high-risk candidates, that is those with 1 or 2 parents with myopia, or those who are in the pre-myopic state, that is with a refraction of +1 to -0.5 diopters post-cycloplegia. So this ATOM-3 study, the report when they published in December 2025, they looked at the effectiveness of 0.01% in young pre-myopes and low myopic children. What they found was that They gave them 0.01% low dose atropine bedtime for 2.5 years, and then they stopped it for a year and looked at the rebound. But they found that there was no statistically significant difference in myopia progression between the atropine and placebo-treated eyes. However, they noticed trends towards less myopic shift with atropine-treated eyes, both in pre-myopia and low myopia. So we may need more validation on this aspect, but right now, this may not be a bad idea to start treatment with low-dose atropine in pre-myopes or low myopes so that we can control the progression. So there are a lot of questions in our minds when you're starting low-dose atropine, how to prescribe, which is the ideal concentration, what should be the dosage, how long should we use, how to stop. All these are very pertinent questions in our minds. So there are a lot of controversies about it yet. So in Indian scenario, I would say that we never had the luxury of the choice till recently. We only had 0.01%. So we definitely started with 0.01% because it was found to have a very good safety profile. But the ideal candidate is a slow progressor or a mild to moderate progressor. So if you have a very rapidly progressing child, 0.01% may not work at all. So you need to start on a higher dosage like the 0.05% as from the LAMP study insight. So right now we have 0.05% also available in the market. So we have both the options. And how do we give the dosage? So when we start with the low dose atropine, ideally once daily dosage, preferably at night, so that it minimizes the daytime photophobia. And how do you follow them up? Every month, you should at the first time when you're starting, you try to call them in a month so that you can look at the look for any allergies, look for any pupillary dilatation, any near vision issues. I tell them if they develop allergy, they will develop immediately and they should discontinue the drug. But in all other side effects, you can wait for a month to, get adjusted to it. After that, I follow up my patients every 6 months with cycloplegic refraction, both manually and along with a dilated autorefractometer and along with an axial length measurement, because axial length is a gold standard in monitoring progression. And how long to continue? That's the question. And when to stop? So the current recommendation is continue for 2 years. This is because all the long-term landmark studies like ATOM and LAM, they showed that atropine had its best effect in the second year. So continue for at least 2 years or till the myopic refractive error stabilizes. Now, if you look at this plot, you can see that in the first picture, that's a younger cohort, and the second one is an older cohort. So this is the COMET study, and you can see that the myopia kind of started to stabilize by about 15 to 18 years, and the axial elongation stabilization happened a little later. So the children who became myopic earlier had a faster progression and ended up having higher myopia than children who had a later onset of myopia. So still you can say that by 18 years, about 50%, 70% would have almost reached the stabilization, and by 24 years almost 90% would reach the stabilization. You would still have a little bit of patients who would be continuing to progress despite reaching the age of 24 years. Now those patients we have to evaluate and see if they have any specific cause for myopia progression. After ruling out all the other pathological causes, then the next
Dr. Neena, your video is, I think, stuck.
happens at more than 0.5 diopters per year, or if the axial elongation happens more than 0.2 millimeters per year despite treatment, that is a non-responder. So what do you do then? The strategy is either to step up the concentration, frequency, or consider a combination therapy. So you can either switch them over to a higher concentration, that is 0.05%. Before 0.05% was available, we used to double the frequency, that is make it twice daily, 0.01%. Or consider a combination therapy with myopia controlling spectacles or orthokeratology contact lenses. Now, how do we stop? Once you find that myopia has kind of stabilized, And when do you say that? As per the ATOM study and the lab studies, if the myopia progression is less than 0.25 diopters per year, it's kind of stabilized. It's not going to increase much longer now. So probably you can consider stopping your treatment of low dose atropine. So that is after they have completed 2 years or they have reached this threshold of 0.25 diopters per year, you can consider stopping it. So how do you stop? Now there is a big problem with rebound for low dose atropine. So you don't stop abruptly. You have to taper and stop. There are two ways you can do it. Either you can reduce the frequency or you can do a step down in the concentration. So when you reduce the frequency, suppose you're using, let's say 0.01% itself, you can, instead of daily dosage at night, you can make it, once, alternate days for the next 3 months. And if they're still stable, you can switch them over to once weekly for the next 3 months and then slowly stop. The other option would be if they are using a higher concentration, you can probably consider reducing the concentration of the atropine from 0.05 to 0.01 for 3 months. Watch out for rebound and then slowly, considering stopping it. So what about safety? This was one question which was asked in the chat box. So we found that it's quite safe drug. So that is why 0.01% has gained a lot of acceptance. The systemic side effects are very low, and all the systemic side effects happen when you have, a susceptible individual, or if they're using probably 1%. So with 0.01%, we haven't seen any systemic side effects. The local side effects like pupillary dilatation, loss of accommodation, a bit of photophobia, near vision blur may happen, but clinically they do not translate into any loss of quality of life. Some patients may develop allergy, lid edema, and some dermatitis. So those patients will have to be tackled accordingly. So there is this dot strategy or the double dot strategy which is recommended so that these side effects can be reduced, the local side effects and the systemic side effects. Second would be digital occlusion of the. So this is the double dot strategy for safety. So I just wanted to share our experience with twice daily atropine a bit. So when we found that 0.01% was not giving us the desirable effects and we didn't have anything else to add, we tried BD dosage of 0.01%, and we had about 38 eyes in both the groups, and we found that there was more than 50% reduction of myopia with twice daily dosage as compared to the once daily dosage. And if you look at the other parameters, that is, you can see the statistically also it was significant. The change in axial elongation comparatively reduced, and the P was significant, less than 0.001, and change in spherical equivalent reduction was also very significant in the twice daily dosing group as compared to the once daily dosing group. Definitely, there was some increase in pupillary diameter from 0.01 to 0.21, but this was not statistical significance. Though it was there a bit, patients didn't complain of any difficulty in near vision. So when should you avoid low dose atropine? Definitely in those patients who are hypersensitive to atropine, you should avoid it. Those who are using other anticholinergics or antidepressants like SSRIs, you should try to avoid because they may have some interactions. Those with cardiac disease, those with angle closure with potential threat to raised IOPs, myasthenia. These are, conditions when you can try to avoid low dose atropine. Definitely when there is congenital heart disease, asthma, then certain cardiac diseases like Marfan syndrome, cone dystrophies, they may increase the risk of photophobia. And in very small children, like less than 5 years, we generally do not start a low dose atropine. I generally start a treatment only if they are cooperative for an axial length measurement on Lenstar or IOL Master. So my cutoff is that. So this is currently the, my practicing protocol for low dose atropine. I start with the lowest available concentration, but the candidate is a slow progressor or a moderate progressor. I monitor them with periodic spherical equivalent change measurement using cycloplegic refraction or cycloplegic autorefractometer, and axial length change with Lenstar or IOL Master, whichever you have. Continue for 2 years or till the myopic refractive error stabilizes. If they are stable after 2 years, you can stop and look for rebound after 6 months. So remember that rebound can happen if if you stop them abruptly. So you can taper and stop, as I mentioned earlier, or you can reduce the concentration. So if there is a rebound with mild to moderate progressor, you can restart the low dose atropine. But if the progression is quite significant, you can switch over to a higher dosage, and you can try a combination therapy with other myopia control measures. Remember, there's an age-dependent effect of atropine, and younger children with early onset of myopia, rapid progression, or parental high myopia may have to be initiated on higher doses itself with combination therapy or with combination therapy. So thank you. And I guess slowing progression eventually translates into saving sight. And we need to consider myopia like a disease and not just a refractive error with great implications.
Thank you, Dr. Nina. Thank you for that concise talk and actually concising the previous talks. To sum up what we have heard here, we have 0.01 and 0.05, but it's still useful and we have to use it judicially. So we have one question from the chat box. How do we assess the pupil size? Is it just based on the symptoms of photophobia, or do you objectively assess the pupil size?
I basically do the biometry itself gives me a pupillary diameter. I don't have any separate instrument for that, but I record the pupillary size before starting atropine. When they come for the initiation of treatment, that time before dilatation, we record the pupillary diameter in mesopic light, and I continue to do that when they come back after 6 months. So that is how I measure the pupillary diameter. Ideal technique would be probably a specific instrument for that, but I get everything done with the lens star measurements that I get.
So I think if you are giving atropine, it is a good idea to keep a record, because it is imperative that you should be knowing what is the pupil size. I mean, normally optical biometers do help in that, but if we want to measure specifically like scotopic and photopic, scotopic, mesopic, and photopic pupil size, we will have to use normally we use a topographer to do that. And in all our patients, if we are planning to start atropine, we would do that. It helps. Actually, what happens is when the patient comes back, it becomes much easier to understand where the symptoms are coming from. Because with kids, they can come back and tell you that they are having photophobia. And especially if you are planning to start atropine, you will be calling them again after 3 weeks or 1 month. So you immediately know that, this is where it is coming from, if you have a baseline pupil size. But in normal cases, we don't measure in all the cases. Like we do measure it with the biometer only, as Dr. Nina said.
Yeah, so we also measure the near point of accommodation and near point of convergence for all the patients, because I found that there was a loss of one or more diopters of accommodation, and there is some receding of your NPC with treatment. But this may be important in children who have accommodative issues or exophoria for near or something like that, who are going into IDS, but other children probably they are tolerated well and they don't have any clinical translation into a loss of quality of life because of that.
Yes. Any experience with an asymmetric pupillary size with low dose atropine? Question to the panelist, Frederick sir, Elizabeth madam, Meenakshi madam, or Jitendra sir. Because I've had one patient with asymmetric pupil dilatation after low dose atropine, and I specifically asked for installation of drops in both the eyes. The child had diligently used it, and on follow-up measure of the pupil size, actually after stopping the drops, it had reduced. So it was less in one eye
No,
and
Lakshmi.
more in the other.
I have never had any experience like that. But the pupil size, as mentioned by all, also gives an idea whether the compliance is good also. So you'll have to, you can have some follow-up on that. That also gives an idea.
So one thing is that they could have put 2 drops instead of 1 drop. Sometimes, the mother or father or they themselves, when they put, they would not be remembering whether it actually went into the rice. And so they could have put 1 more drop in one eye as compared to the other eye. That is a possibility. And also, you also should recommend that they buy the drops from an eye hospital, because if they go out, they will be given 1% atropine.
Yes, yes.
They don't look at the dosing at all. They will
Yeah.
be just given 1% atropine and they will put it and they'll come back to you with
Yeah.
severe symptoms.
There's one more question in the chat box, whether there are any psychological effects on the child or scholastic performance with I don't get it, whether it's with progressive myopia or low-dose atropine. I think it's to low-dose atropine. Are there any psychological effects?
They are not
Atropine.
published.
Yeah, please go ahead.
No, please. So there are no published side effects. I mean, I've never read about it. I never saw it, and I have never read about it. Maximum, what has been reported is there are 3 cases reported by me here post intermittent exotropia, and I saw 1 case being reported in this year's IMARC, where they reported that the exophoria patient got, or rather, patient had orthophoria before using atropine and went into esophoria after using low dose. Yeah, so that has been reported, but never read about any psychological complaints by the parents that atropine is creating that.
So you have to check with the strength. Atropine does
Yeah,
have
exactly.
anticholinergic side effects. We know as mad as a hatter, as red as a beet. All these things are possible with high doses. So with low doses, we have never had any of those problems.
There was a lot of discussion on how we are seeing myopia progression in older children also. Though we say younger children is a fast progression, there's been a lot on how we are seeing it with the board exams at 10, 12. So the consensus seems to be that we start atropine, minimum age is 5 years. So I just want to ask the panel, what is the maximum age you have started atropine at? Meenakshi ma'am.
Started at 15, 16.
I started just pre-board exam kid. Yeah, so no progression for a very long time. And then, sudden progression. So around, say, age 14, 15, I've had to start.
And you had them for 2 years, ma'am? Did you?
Yeah. I mean, through entrance, beyond.
Okay.
And but it's the same. You have to document that there is no further progression based on whatever we have been talking about, the same, regardless of age, cycloplegic refraction, axial length. And then, it's the tapering, everything is the same regardless of the age.
Yeah, I have a question. What is the panel's take-home message about pre-myopia? If the child is found to be, say, plus 0.5, a 5-year-old child with both parents myopic, do we start medicine or do we wait till progression? That's a question to be answered.
I think progression is the key. We are all at the end of the day. No, you have to wait. Progression is what atropine is going to prevent. So we have to document the axial length. We have to document that child is losing the hyperopic reserve quickly, or at least he's losing the hyperopic reserve, and axial length is also building up. So we do need at least 2 important data. One is the cycloplegic refraction, that it is going from plus towards emmetropization and towards minus, and there is evidence that this is occurring mainly because of the axial growth, and only then we can start atropine.
See, in our peculiar scenario in Kerala, most of the youngsters are abroad. They are either in the Gulf, they're in the Canada, and in Canada, in Gulf countries, they don't give atropine as frequently as us. And these children visit us maybe once in 2 years, once in 3-4 years. So if you pick up a pre-myope and start atropine, say the same scenario which I said, we have the baseline axial length, baseline keratometry, and if the refraction, cycloplegic refraction is just 0.5, plus 0.5, parents, both of them are myopic. And in that situation, whether to wait for 2-3 years for the child to come back or just take a chance and give, what is the complication? There are no complications, no? Even if you start.
But the chances, okay, so the numbers are very important. The numbers that you are a myope and you would progress is much higher. So almost 70% in our practice, I have seen that at least 70% of them do practice, whereas the pre-myopes, almost 60 to 70% may not, progress and become a. So the number is very important, that the number of times a pre-myope would become a myope versus a myope would progress. So if in a myope, you start atropine, even in absence. So I don't recommend that. I don't do it in my practice. So if you recommend that if patient has come for the first time and you can start atropine, and the chances that the patient would progress is much higher compared to a pre-myope becoming a myope. So that is very, very important.
Dr. Elizabeth, I
I
worry
just
that
want to
someday you will get sued because you disturb the quality of life by making the put the drops in every day for years together with no objective evidence. I mean, I have a vivid imagination, but I do imagine something like that. So better maybe to scare them so much that they will bring the child back the next year for you to document the progression.
They'll
Then
take
we're
a
all
flight
safe.
and come back.
Yeah.
We should not forget that the child is likely to emetropize. I mean, we should not give away or lose the basic concept of emetropization towards which every eye probably tends to grow. So, as Dr. Jitendra said, that they may just not progress. That plus 0.5 may last for another 2-3 years. Maybe just scare them, as Madam said, to come back and give the lifestyle measures. So, make them go outside and use the video games, etc.
But I have seen this trend this thought happened because one of the parents asked me. So he is the father of 3 children, and the elder 2 kids have compound myopic astigmatism. Astigmatism is minimal, only about -1.5. So I've been seeing him for the last 10 years. So the third kid he bought, and he told me, "Can you look at him and see if he's myopic?" So I did cycloplegic refraction. He was only plus 0.5, and I happily told him that there is no myopia right now. So he told me that, and he had some mild astigmatism. So the spherical equivalent was not bad. So I told him no. Then he said, "This is what you told my second kid 2 years back, and then next year he became myopic. So are you going to do something about it or not?" So that is how I have been trying atropine for pre-myopes. So I cannot vouch for anything now, but I have to see my results. So in very high risk individuals, probably it's not going to harm anything. It's not going to harm. I don't know whether it'll benefit or not, because the Atom 3 also didn't come out with any conclusive evidence. They said there was a trend towards less myopia in these children, but there was no statistically significant reduction in the parameters. So I would rather start rather than doing nothing, because they're all abroad and they're all in Gulf. These visual environment modifications are not going to work.
Yeah, I had a
So-
patient similarly in Finland where there is no sunlight for 6
No
months.
sunlight.
So, and both parents are high myopes. So when we discussed, the parents were very keen. We said, we understand that he's still a pre-myope. We understand all the statistics, but there is, and they go to schools where there is a lot of gadget. So sometimes I agree with Nina. Sometimes anecdotally, you may have to prescribe.
No, but you can see what you can do is you can have very robust data. We actually published our work. You can have very good data on, especially these kids with Dr. Nina is talking about. These are the patients which are, very good, robust data, because see, you can easily, that the elder 2 children, were myopes or became myopes, and the younger kid, you have the data, and it is, once the patients, the parents know that they are myopes, their other 2 kids are myopes, they would come to you, maybe even if you call
Yeah,
them
they
at 6
will
months,
come.
they will come in 3 months.
They'll
So
come.
that data helps, at least the data reduces the guilt that, you meddled with the emetropization, as Dr. Prachi said. At least that reduces the guilt part, that that, you have sufficient data to suggest. And that is how we started doing that work. And the reason why I think Atom 3 could not find much of significance was that even otherwise, a lot of pre-myopes, I don't know what kind of pre-myopes they took, because the pre-myopes normally also, the number of patients who would convert into myopia, the percentage is less. So not the number of
30%.
pre-myopes.
That percentage is 30%.
Yeah, so that is pretty low compared to a normal myope who would further progress. But if you have a good data that, they have been progressing over a period of 1 year, those patients normally would tilt or would go towards myopia. There we can start low dose atropine.
Yeah, that's the basis of the next question, that what age should you start screening for a child for myopia if the both parents are myopic? So how early should you, that's the question. But
I'm also going to add one more question to that for people to answer. I mean, a lot of the discussion has been about focusing on chair time and counseling. Because putting drops for 2 years every day is a huge deal. Any suggestions, tips on compliance that any of the expert panels have tried that you would recommend?
The best thing is a switch to optical therapy. That is not our discussion today, but if the patient is not compliant to putting the drops, the best thing is to switch to optical therapy. That is supposed to be better, actually. And I would like to say that the International Myopia Institute, IMI, they have recommended that pre-myope from plus 0.75 to minus 0.5 has to be interfered. We have to intervene. That's the recommendation.
Sorry, I'd like to answer the question on how soon you should screen. I'd say as soon as they can bring the child.
Yeah, that's what.
Yeah, there's no point in delaying, because maybe the treatment you may want to start later if treatment is required. Maybe some documentations you can't do, but lifestyle modifications can happen right away. And no better than two myopic parents to know how important it is. The problem often is the child is left with grandparents. So ideally, if you want to counsel, you must counsel who the person who takes care of the children, of the child. That is the question to ask them. And if it is the grandparent, please bring them to the clinic and talk to them.
I have one more question to the panelists. Like, if a child is started on atropine for a purely unindicated case, like an astigmatism with adequate hyperopic reserve, would you stop the atropine drops immediately, or would you be worried about rebound progression?
What rebound? Is the patient already hyperopic? What rebound he will? No, I have stopped in a lot of patients.
Yeah.
No, I have stopped in a lot of patients. I get a lot of patients as a third or fourth opinion for atropine just because they have myopic astigmatism or maybe a mixed astigmatism. I have stopped in a lot of patients, not really afraid of rebound. There's hardly any rebound. He's already on the hyperopic side, so there is nothing. We are not really afraid of rebound. You just have to, tell them that you'll have to wait. The time of atropine will come once they lose this hyperopic part.
So
Jitendra, you've just started gray hair. The more gray hair, the more fourth and fifth opinion you will get.
And you have to be more careful about not to disturb the sensitivities of previous 4 opinions.
Oh, yes.
Yes.
So nowadays people come with everything, myopic glasses, low dose atropine at the when the myopia is diagnosed itself, they give everything together, one shot. They don't even look whether the axial length is increasing or myopia is progressing. So it's like full throttle as soon as they diagnose myopia. So we do get a lot of second opinions for that also.
I think that is where this particular myopia module was targeted, that we should have more awareness about the fact that we are not treating myopia. We are actually treating myopia progression, and so once we have a documented progression, only then we can think of starting some treatment.
I think if the discussion has come to an end, to sum up what we had today, 0.01% and 0.05% has its role. It has to be used judiciously. Age, family history, and a baseline refraction are very important, and it should be considered in treatment. And pre-myopic patients might have to be considered, especially in the presence of a family history. Follow-up with axial length and cycloplegic refraction is a necessity while managing progressive myopia. And counseling the parent with an adequate chair time would be very important in managing progressing myopia. Outdoor activity has its importance and it cannot be stressed more. should consider combination treatment or higher dosage whenever necessary, and should follow up the child even after cessation of atropine treatment to detect rebound progression. So that would be our take-home message from the module, I feel. So thank you all panelists for having an active discussion here. Thank you, Jitendra sir. Thank you, AAOS. And I think we can wind up the session with that.
Yeah, there's a link in the chat box with regards to the questions which are to be answered for getting the certification. So just thanking all the panelists and the speakers. Great job by Dr. Prachi, Dr. Jaspreet, and Dr. Neena. And a wonderful job by the moderators, Dr. Satya and Dr. Lakshmi. And thank you so much, Meenakshi ma'am, Elizabeth ma'am, Frederick, and Dr. Siddharth. So thank you so much for, accepting this invite. Thank you so much. Have a great evening.
Thank you.
Thank
Thank you,
you,
Dr.
AOS, for
Jitendra.
the opportunity. Thank
Thanks.
you.
Thank you, Dr. Jitendra, for inviting me.
Thank you.
It was a nice presentation, very nice talks by everyone. It was very good.
And a very, very timely webinar series, much needed to clarify so many questions and doubts. Thank you so much, Jitendra, for this.